Hello, Priyanka. All set?
Yes, ma'am.
Good evening. All set? Good evening. All set?
Yes.
Have you checked your slides?
Yes, ma'am.
Okay.
Share screen.
Abhijit has checked the slides. Abhijit,
Yes, ma'am.
hello, welcome. Have you checked your slides?
Yes, ma'am. I checked slide.
Hello. सर आले का डॉक्टर निरंजन चव्हाण आले प्राची डॉक्टर प्राची
Unmute. Dr. Priyanka, unmute.
Hello, welcome, Dr. Nikita.
Hello, good evening, ma'am.
Good evening.
Good evening,
I
ma'am.
think Dr. Niranjan Chauhan is yet to join.
Hi, Nikita. Unmute करो.
हाँ, कैसे हैं आप?
अच्छी हो, तुम कैसी हो?
मैं बढ़िया हूँ बिल्कुल.
I think Dr. Niranjan Chauhan is yet to join. Na?
He's not seen.
Yes, ma'am. Yes, ma'am.
Hello, ma'am. Good evening, ma'am.
Hello. He's joining.
Bhakti is not seen today.
Bhakti's mother in the past away, no?
Huh? Today?
No, 2 days back.
But the news is, I have not seen the news.
It's 7 o'clock.
Hmm.
Oh my God. Sumit's news we got. Bhakti's news was not sure.
Madam, we can start.
Okay.
Hmm.
Should I start, ma'am?
Actually, it's 6. Just can you wait for 1 minute?
Okay, ma'am.
Niranjan Chauhan join.
Yes, ma'am.
Just wait for 1 minute
Yes, ma'am.
because already I talked with him.
Okay.
Dr. Abhijit is present here.
Yes,
ma'am.
he's there.
Yes, he's there.
Wait a minute.
So Dr. Komal is also joined here. I mean, it is Dr. Komal or Dr. Niranjan? I can see Komal's name.
I think Dr. Niranjan must have joined in.
Hi, Komal. Hi, hey, Dr. Yeah. So my guess
No.
was correct.
Welcome, Dr. Niranjan.
Yeah. I'm sorry. There is some. I can't change the background now, but I'll try to.
No worry. Welcome, Dr.
problem.
Niranjan.
Welcome. Okay.
Yeah,
Shall we start?
Yeah.
You can start. Priyanka?
Yes, ma'am. Yes, ma'am. Good evening, everyone. Myself, Dr. Priyanka Shelkar, working as an assistant professor at Government Medical College, Nagpur. Here, I welcome you all in October PG education program. This is a 13th series which is going on, and today we are going to discuss on malignant ovarian tumor. So, without wasting any time, I would like to request Dr. Sushma ma'am to start with your welcome speech, ma'am.
A very good evening to all. शुभ नवरात्रि. आज 5th डे स्कंद माता. देवी का यह रूप यानी हम बच्चों को सभी आपत्तियों से दूर रखना. महिषासुररूपी रावण, ovarian malignancy is there to threaten our lives. So with the prayer Ma Durga Mata, we'll start our webinar. So today really it gives me divine feeling to welcome you all on our 13th webinar of PG Star Series by Nagpur OBGYN Society in association with the Government Medical College, Nagpur. Thanks to Dr. Manju Vaikar. Now the malignant ovarian mass is really like a demon, but it is a chupa demon. There is an occult, many times difficult to diagnose in the initial stage. So our angels took the challenge to fight with this demon. Dr. Abhijit Verakar, the little angel, the budding gynecologist, ventured to fight with this demon. He is going to present a case on ovarian malignancy. Sir, other senior academic genius angels, Dr. Niranjan Chavan from Mumbai and Dr. Nikita Vijay are there to supply him different astra and shastra so that he should win the battle. He should win the battle. So welcome Dr. Niranjan Chavan and Dr. Nikita Vijay. But the onco battle won't be ended as Durga Mata fought for 9 days with different avatars. In the same way, we need to invite another intelligent, talented angel, Dr. Mukesh Bang, to deal with this malignant demon. Now, Dr. Mukesh Bang is well versed with the Rananiti and well equipped with all updates. And he is going to speak on ovarian cancer, how to treat and update. Welcome, Dr. Mukesh Bang. Our another brilliant angels, Dr. Ashish Zararia and Dr. Tanushree Jain, are also well equipped to provide the perfect solution of the weapons. Welcome, Dr. Ashish Zararia and Dr. Tanushree Jain. Our MOC, Dr. Priyanka Shelkar, will be coordinating this war very nicely. Our another angels, Dr. Anuja Bhalerao, Dr. Prachi Dikshit, Dr. Bhakti Gurjar, and our secretary, Dr. Pragati Kharatkar. They are working and fighting tremendously with these evil demons, and so they can provide the appropriate weapons to all budding angels. So let's enjoy this war with ovarian malignancy. Thank you. Can start. Priyanka?
Unmute yourself, Priyanka.
Priyanka, unmute.
Should we finish with
Priyanka,
Yes, ma'am.
unmute yourself.
Yes, ma'am. Yes.
Yeah.
Now we are moving towards our first case discussion, that is on ovarian malignancy. Our presenter is Dr. Abhijit Virakar and our examiners are Dr. Niranjan Chavan sir. Sir is a professor and unit chief at Sion Hospital, Mumbai. Sir is a president MOGs, organizing secretary at AICOG. Sir, having 60 publication in international and national journals, coordinator of 11 batches of MUHS recognized certified course. Sir is coordinating more than 3 batches of advanced minimal access gynec surgery. Our second examiner is Dr. Nikita Vijay, ma'am. I welcome you, ma'am. Ma'am is associate professor at Lata Mangeshkar Hospital, Nagpur. Publications, ma'am, having many publications at national and international level. Madam is the author of role of tranexamic acid in reducing the blood loss during cesarean section. Recently, ma'am received International Best Researcher Award through ISSN. Now, I would request Abhijit to share his screen and start with his case.
Good evening, everyone. Myself, Dr. Abhijit Varakar, junior resident working in OBGYN department of GMCS Nagpur. And today I am here presenting a case on malignant ovarian mass. My patient is a 70-year-old named ABC, a para to live to residing at Chandrapur, farmer by occupation, who is illiterate and belongs to lower socio-economic class. Came to the OPD with chief complaint of pain in abdomen since last 1 month, abdominal distension since last 1 month, and generalized weakness since last 3 months. History of presenting illness. Since last 1 month, patient is having dull aching pain, which is insidious in onset, without any aggravating or relieving factors. The history of abdominal distension, which is gradual in onset, progressive in nature, with bloating sensation since last 1 month. The history of nausea, early satiety, generalized weakness, loss of appetite since last 1 month. The history of loss of weight in around 3 to 4 kg over last 1 month. There is no history of urinary complaints, no history of heartburn, vomiting, no history of any discharge per vaginum, any bleeding or spotting per vaginum. There is no history of fever, cough, and breathlessness. Menstrual history. Patient has attained menarche at 15 years of age, had a regular menstrual cycle of 3 to 4 days of bleeding, and 28 to 30 days of cycle with average flow. Patient attained menopause 21 years back, and the menstrual lifespan of the patient is 34 years. Obstetric history. Patient married at the age of 16 years, married since 34 years, and husband died 8 years back. She is a para 2 live 2, both normal vaginal delivery, uneventful pregnancies, both delivered at home with normal purpurium. The last childbirth was 43 years back, and duration of breastfeeding is approx 1.5 to 2 years per child. There is no history of sterilization. Past history, there is no history of hypertension, diabetes, tuberculosis, asthma, any cardiovascular disease. There is no history of any malignancy or any surgical intervention. There is drug history. There is no significant drug history. There is no history of uses of contraceptive pills or treatment of infertility. Family history. There is history of endometrial carcinoma in sister who died 9 years back due to the same. Personal history. Patient consumed mixed diet, had decreased appetite, normal sleep patterns, bowel bladder habits are normal without any addiction and substance abuse. Summary of the history. She is a 70-year-old para to live to postmenopausal patient with vague abdominal pain, abdominal distension, generalized weakness since last 1 month, associated with loss of appetite, early satiety, and significant weight loss with family history of endometrial carcinoma. General examination. She is conscious, oriented to time, place, person, thin build, catch exit, with height of 137 centimeter and weight of 45 kg, BMI corresponding to 230 kilogram per meter square. She is afebrile with pulse rate of 88 per minute, regular, normal volume, equal on both sides, with a respiratory rate of 16 per minute, and blood pressure of 118 by 68 millimeters of mercury in sitting position on right arm, maintaining saturation on room air. She had a pallor with no icterus, cyanosis, clubbing edema, or generalized lymphadenopathy. Thyroid and breast examination was found to be normal. Spine examination was normal. Gait was normal. On systemic examination, cardiovascular system, respiratory system, and central nervous system, no abnormality detected. On per-abdominal examination, on inspection, abdomen appears to be distended more in the flanks. The abdominal skin was tense and shiny. All quadrants move equally with respiration. Umbilicus is midline, everted. Dilated veins seen on the abdomen, no scars and sinuses present, hernial orifices found to be normal and intact. On palpation, there is no local rise of temperature, tenderness, guarding, or any rigidity seen. Mass of approx 15 by 15 centimeter felt occupying in the lower portion of abdominal region into the hypogastric region, which is variable in consistency, non-tender, with irregular surface and irregular borders. All borders are made out except the lower border, having restricted mobility. There is no evidence of any other organ megaly. On percussion, shifting dullness was present. Free fluid was present in the abdomen. On auscultation, bowel sounds are heard in all the quadrants. On local examination, external genitalia appears atrophic, external urethral orifice is atrophic, and no signs of stress incontinence. On perspiculum examination, vagina was atrophic, pale. Cervix was postmenopausal flushed with vagina and mid position. There is no evidence of bleeding or any discharge or growth seen on the cervix. On pervaginal examination, cervix felt atrophic flushed with vagina, non-tender. Uterus was a small size, anteverted, firm, non-tender, and appears adherent to the mass anteriorly. There is a mass of variable consistency which is felt occupying the right fornix of size 15 by 15 centimeter and extending into the right, anterior fornix, which is non-tender with restricted mobility and irregular surface and margin. Fullness in the posterior fornix felt. There are also nodules felt in the pouch of Douglas, which are non-tender. On rectovaginal examination, our findings were noted rectal mucosa free. Provisional diagnosis: my patient is a 70-year-old paratolito with postmenopausal woman with right-sided ovarian mass with ascites with possibility of malignant nature under evaluation.
Yes, sir.
Can we go ahead, madam?
Abhijit, go back to your history slides.
Yes, ma'am.
Okay. So your patient is 70-year-old.
70-year-old.
If I say no age is immune for the ovarian malignancy, how will you explain this statement?
Ma'am, though malignancy can occur in any age, but some malignancies like epithelial ovarian cancer that tend to occur into the older age, that is into the 60s of the patient, while some malignancies like germ cell tumor which occur earlier into the 20s of the patient, and some low malignant potential tumors which occur into the 40s of the patient.
Even hereditary ovarian tumor also, they
Hello.
Tend to occur earlier,
yes.
a decade earlier.
Yes. Next slide. Pain in abdomen and abdomen. Next slide. Okay. Tell me what are the points in your history that is favoring your diagnosis?
Ma'am, patient is a 70-year-old
Yes.
with complaining of dull aching pain, abdominal distension, with history of nausea, early satiety, weakness, and weight loss,
Okay.
which point toward malignant nature of the condition. Further, there is no history of contraceptive pill uses in the patient. And on examination, there are findings which suggest that there is a tumor which is arising from the right adnexa, separately felt from the uterus, which can point toward the ovarian malignancy. Further, ascites is present.
Okay. Go back to your menstrual history slide. Sir, please, you want to ask? Sir, please unmute yourself.
Madam, you please continue. Let it be in the flow as what you want, so that he will be in a better position to answer. I will talk later.
Abhijit, I want to know how menstrual history is important in your case.
Ma'am, in ovarian cancers like early menarche and late menopause, these are the risk factor for the cancer.
Auntie.
Okay. Go back to next slide. And how obstetric history is important in your case?
Nulliparity is also a risk factor for the ovarian malignancies, while pregnancy and breastfeeding are protective in nature.
Can you explain how the pregnancy and the breastfeeding protect from the ovarian cancer?
As the number of ovulatory cycle increases, this increases the risk of ovarian cancer. And in pregnancy and during the breastfeeding, as ovulation is suppressed, so it is protective in ovarian malignancy.
Okay, you have mentioned there is no history of use of hormonal contraceptives.
Hormonal contraceptive pills.
What do you mean by this?
Hormonal use of hormonal contraceptive pills is also protective in case of ovarian malignancy. Their use for more than 5 years, it actually reduces the risk of ovarian malignancy by around 50%.
But how? What is the mechanism for that?
A mechanism is same. The hormonal contraceptive also suppresses the ovulation and protect from the ovarian malignancy.
Anything else in the mechanism for the protection? The OC pill induces the apoptosis. Okay. So in this way, it is helpful to prevent the ovarian cancer.
Ovarian cancer.
Next slide.
Excuse me,
Yes.
can you just go back to this slide? What just one small mistake is there. Married 34 years back, he has written over there, and last childbirth 43 years back. So I think, Abhijit, please correct it.
Correct.
Should be the other way around.
Yes, sir.
Very good observation by the third umpire.
Yes, yes.
So,
Actually,
sorry.
she's married since 45 years, actually, not 34.
Okay. So now you have a ovarian tumor. How will you further go ahead? I mean, of course, ovarian tumor, we have probably 15-20 minutes, madam, now. Hello.
Yes, sir.
We have to proceed.
Yes,
Sir,
sir.
we have adequate time.
For 1 hour, we can do that.
No, I mean, we both examiners, of course, because ovarian tumor is a very vast topic and there are so many things which are involved. And I remember as a postgraduate student, when I was there, I used to take at least 5 hours to read it. And
Yeah.
cancer, 4 to 5 hours to read it, and also from other things. So from this point of the exam, we will try to cover as many as points of ovarian cancer. Of course, you have presented very well and absolutely great. But 50%, only 35-40% of marks you have covered now. But the rest is all the discussion and how you answer your questions and how you are able to justify your answers. And examiner would like to see that whether you are standing in between or whether you are on one side or on the other side. So he will try to pull you and try to drag you in the wrong side, but you should be able to stand where your point of view is there, and you need to give reasons for why you have chosen this answer, and then that is how the further marking will occur, and they need to know your expertise of managing such a case, either by your superior or your unit head or a professor or like any faculty, or probably you have assisted or you have seen. So that also all counts. So now tell us what are the different types of ovarian tumor you have seen in your 3 years of residency or two years of residency. Theoretically, we are aware that there are so many different types of ovarian tumor, but to play with exactly how many types of ovarian tumors you have seen.
So, during the residency, we have seen epithelial ovarian cancer, the serous cyst adenoma we have seen. Then we have seen thecoma in an elderly patient. Then we have also come across a case of
You have seen only in the postmenopausal or menopausal age, or you have seen also adolescent girl tumors?
so postmenopausal females.
Okay, so there are also patients which are common in adult. What ovarian tumors are common in adolescent girls? Can you highlight on that?
The germ cell tumors like dysgerminoma are common in early 20s.
Yes, yes. No, no.
Then
They are even found at 14 years of age, 13 years of age, just
yes,
time of menarche. Probably your seniors might have seen it, or you might have not been so lucky to see all these cases. But there are immature teratomas, yolk sac tumor,
yolk sac tumors also.
all these things also are coming. So now, which are common? Solid tumors are common, or cystic tumors are common in ovarian tumors?
Cystic tumors are common.
Which is larger, whether it is a mucinous cystadenoma or whether it is a serous cystadenoma in the form of dimensions?
Serous cystadenoma.
Mucinous cystadenoma is more larger in dimension as compared to the serous cystadenoma. And what is the age of the decayed germ cell tumors are more common? Dysgerminomas, are they more common in reproductive age, menopausal, or in adolescent age group?
More common in adolescent age group in early 20s.
Common from 10 to 30 years of age. It is also in adolescent as well as in young women.
Yeah.
And what other in different type of microscopy you see in your ovarian tumors? Like you will see signet rings. In which condition you find signet rings?
In Krukenberg tumors, we will
Yes.
see signet ring appearance.
Then the leading question is, what is Krukenberg? Because whatever you talk, it will be leading the question. What is Krukenberg tumor?
The Krukenberg tumor are the secondaries to the ovaries from the primary, from the abdominal, from other cancers like breast cancer, colon cancer, stomach cancer.
Okay. So it primarily arises from the gastrointestinal
tract.
side. Okay. And less commonly from the other sides.
Other side.
Often these tumors are bilateral in 80% of,
Bilateral.
and they are a metastatic nature, and that's how they spread further. How is the spread? The spread is either transcelomic, it could be lymphatic, direct, or hematogenous. Okay.
Yes.
Now, what are the other tumors you have come across? What are Schiller dual bodies?
The Schiller dual bodies are seen in yolk sac tumors.
Yes, you are very much right, and they are found. So, what is yolk sac tumor?
So, yolk sac tumor is a germ cell tumor, which is commonly seen in children, that is in early ages.
Children बोलेगा तो तू फिर वो
early 20s.
less than 12 years of age, no? 12, 14 years. It is found in adolescents 16 to 18 years of
18
age.
years.
14
Yes,
years
early
of age.
20s.
It's 100% unilateral. It's
Unilateral.
a lateral tumor, and it's highly malignant, rapidly growth. It is soft and grayish and brownish in color, and microscopically there are Schiller dual bodies. And what are those? Those are basically characterized by the presence of a central blood vessel surrounded by layers of tumor cells. Now, what is embryonal carcinoma?
Embryonal carcinoma is also a type of germ cell tumor.
Yes. Yes. It is also more commonly seen in
Common in
girls,
early
and
20s.
it is the most malignant tumor. It is a very rarest of rare. The tumor markers are HCG and alpha.
Alpha fetoprotein.
Yes. So these are all the different type of tumors you should be knowing, though it commonly you do not come across. Okay. And
Yes.
now we will, there is something about, screening. Screening also, is screening universal in ovarian tumors, or is it?
No, sir. No universal screening is available for ovarian cancer, as their predictivity is less.
Yes. So there were many modules which were presented, but eventually at different age groups, and the different types of the array of so many tumors around. You cannot pinpoint a particular a method either by ultrasound or by Doppler or by tumor markers, where there are various tumor markers. You cannot have a proper, you cannot justify, because you will miss out. So that is the reason. But the commonest one, what is the commonest tumor marker you come across in your practice when you
So
have?
CA125.
What do you mean by CA125? The CA125.
This is non-specific marker.
Okay.
No,
No,
it is
it's
generally
a specific marker for epithelial tumors. How can you say it is a non-specific? It has a specificity regarding epithelial tumors. Serous and mucinous cystadenoma, obviously they are elevated in that. It could be non-specific because it is also raised in
also elevate other
like
conditions.
immunodeficiency or patient on tuberculosis drug
Tuberculosis, endometriosis.
or GI syndrome, GI pathologies, or as you said, endometriosis. That is why. But for epithelial tumors, of course, there are further tumor markers. It's basically an antigen which is found in the fetal amniotic and the coelomic epithelium in adults. And it is also found in the mesothelial cells of the pleura, pericardium, and tubal endometrial. And it's elevated in 50% of stage 1 and 90% of women in advanced disease. What is the normal level of CA125?
No, less than 35 is the normal level of CA125.
Nanomillimoles, or is it nanograms per ml, or is it ml per dl? What, I mean, you should be specific about that. Okay.
Yes, sir.
Madam, you want to ask any further questions? I just taken 7 to 8 minutes, but you can surely go ahead.
Okay, sir. Abhijit, what do you mean by borderline tumors?
Borderline tumors are low malignant potential tumors which fall in between the benign tumors and malignant tumors. They have features like cellular pleomorphism, increased mitotic activity, but stroma is intact in them.
What are the characteristics other than that?
I mean,
They occur at an early age.
Early age, that's in the 40s of the patient.
And they are confined to the ovary for a prolonged period.
For prolonged period. They almost
the prognosis is good.
Good prognosis. Right?
Yes.
Only.
As you have mentioned, there is the germ cell tumor. They occur at the early age group, and your patient is a epithelial ovarian cancer that is in the postmenopausal patient.
Postmenopausal.
Can you tell me how the management is different in these two conditions?
In case of epithelial tumors, which generally occur in postmenopausal patient, we have to go for staging laparotomy.
Okay.
And if a family is complete as in postmenopausal period, we can go for TH and BSO. But in cases of germ cell tumor, we have to preserve the fertility of the patient. So we need to go for preservative surgeries like unilateral salpingo-oophorectomy.
Okay. And is there any role of fertility preserving surgery in epithelial ovarian cancer?
Patients is requiring fertility, then we can go for fertility preserving surgery.
In which
if
stage?
The tumor is confirmed.
Yes. In which stage, up to which stage you can go for the fertility sparing surgery in a epithelial ovarian cancer?
Up to stage 2.
No. No.
Ma'am, in only stage 1A.
1A and grade?
Grade 1 and 2.
1 and 2. Huh? Yes. Not in grade 3.
Yes.
Okay. Yes. Sir.
Okay. Now I'm going to go to before the management. There are certain.
Actually, diagnosis.
Sorry.
Yes, sir. Investigation and the diagnostic part.
Yeah, we will go to that investigation and diagnosis. We have, I think, 10 minutes now. But I want you to tell us what is Roma index, what is RMI index, and what is IOTA classification.
Yes.
So Roma index is a risk of ovarian malignancy algorithm in which the values of CA125, HE4, that is human epididymis protein factor 4, and the postmenopausal status of the female is taken into consideration. According to that, we can the algorithm predicts the risk of ovarian malignancy. In ROCA, it is the risk of ovarian cancer algorithm in which the serial CA125 values are taken into consideration to predict the risk of ovarian malignancy. And RMI square, it is the risk of malignancy index in which three parameters are considered: ultrasound score, then CA125 values, and menopausal score of the patients. In RMI, there are ultrasound score will have 5 features like multilocular cyst, the presence of solid areas, presence of ascites, presence of intra-abdominal metastasis, and the bilateral of lesions are taken into consideration. Out of these 5, if no abnormality is there, then we give the score of 0. If one abnormality is present, then we give score of 1, and if 2 or more, then give score of 3. Then for menopausal status, the premenopausal females are given score of 1 and postmenopausal females given score of 3. And if the total RMI score is more than 200, then it is more likely to be malignant tumor.
What are
Yes.
the limitation of RMI and what are the different types of RMI you know?
Ma'am, limitation of RMI is that in RMI, more importance is given to CA125 value, which is falsely positive in some other cases also. And there are different types of RMI like RMI 1, 2, 3, 4. And after RMI 4, we take tumor size into consideration also.
Okay. Any other limitation of RMI? Actually, we are using the RMI to know the risk of malignancy, but actually it doesn't tell about the risk of malignancy. What is the better risk model?
Ma'am, Roma and Roca is better.
Anything else? Nowadays, very much in fashion.
Yes, ma'am. We can do go for OVA Sure or OVA 1 panel.
No. Have you heard about the IOTA ADNEX model? IOTA.
There is IOTA classification which is based on USG finding. They have given certain B rules and M rules. The B rules are that on USG, the cyst should be unilocular. There should be presence of acoustic shadow. There should be presence of solid components. The largest diameter should be less than 7 millimeter. There should be soft, smooth multilocular cyst with diameter less than 10 centimeter, and there should be no vascularity. And the M rules which point toward malignant tumor, there is irregular solid tumors, presence of ascites, then strong blood flow on Doppler, and irregular multilocular solid tumor more than 10 centimeter, and there should be papillary projections at least 4.
Okay. What are the benign descriptor according to the IOTA, and what is IOTA ADNEX model?
Sorry, ma'am.
What are the various benign descriptors suggested by IOTA group, and what is IOTA ADNEX model?
Sorry, ma'am. I don't know about that.
And currently, IOTA is advising two-step strategy. What is that two-step strategy suggested by the IOTA group? The benign descriptors are, they have given 4 descriptors according to the pattern recognition on the ultrasonography. Okay, so they have given the unilocular cyst with the ground glass appearance. They are endometriosis in the premenopausal women, unilocular, that is they have done the modification here also. They have mentioned the size also, that is less than 10 centimeters. Second group is dermoid, description of dermoid, unilocular cyst with the mixed echogenicity, less than 10 centimeter size, again in a premenopausal women. Third is anechoic cyst, less than 10 centimeter, unilocular cyst in a premenopausal woman. These are the benign descriptors, modified benign descriptors they have told. And what is aorta adnex model? And what is the two-step strategy? They are saying in all adnexal mass, you first go for the benign descriptors, modified benign descriptors. And if they are not classified into these all four, we have given one is endometriosis, second is dermoid one, third is the cystadenoma or the simple cyst, then you should go for the adnex model. Adnex model is assessment of neoplasia in the adnexa group. So for this, they have given 9 variables. 3 are clinical and 6 are ultrasonographically. So what is the benefit of aorta adnex model? Then not only differentiate between the benign as well as malignancy, they also subgroup it further, like in a borderline stage 1 or the stage 2 and 4 and the secondaries. So they further divides also. They tells about the staging also. So this is the nowadays this is the latest one, aorta adnex model and 2-step strategy.
Okay, now we will go to the management. How will you manage this case, doctor?
Sir, first we go for ultrasound, transvaginal as well as trans.
First, you talk about routine investigations, you talk about specific investigations, and then you talk about the other things. Do not directly go for ultrasound. She's a 70-year-old menopausal woman. How will you manage this case? So,
we will do the routine investigation.
says, or will you admit her? That is important question.
Yes, sir.
Will you admit her or will you manage her on OPD basis?
So we will admit the patient.
Yes.
We will do the routine investigation like complete blood count,
Yeah.
liver function.
Yes. So remember always, though you are very learned and you are very good and intelligent and you are well read, but when it comes to practical exam and when you come to case presentation, do not directly jump to CT scan, MRI, ultrasound. Okay, you have to go methodically as how you have taken the training during your residency program. Okay.
Yes.
So you have to first admit her, collect her blood and send her for investigations. And you need to also do investigations regarding your suspecting ovarian malignancy. That's your provisional diagnosis. So you need to do blood investigation related to tumor markers.
Yes, sir.
So please go ahead.
So in routine investigation, sir, we will do a complete blood count, liver function test, KFTSC, blood group.
No short forms. What KFC, FCU? I heard.
So we will do liver function test, kidney function test, serum electrolyte, then the HIV, HCV of the patient, blood grouping, RS typing of the patient. Then we will do the tumor markers like CA125.
Blood sugar. What about diabetes? ELBS. That is also important. No? They are diabetic. They are hypertensive.
Yes.
Yes. Then what up? Then you thyroid, very good
profile. And then we will go for tumor markers. If
she is hypertensive or she is you need to get one ECG done, then you need to get urine routine microscopy, then tumor markers, then imaging science comes. What other imaging things you will see?
In imaging, first we will go for ultrasound and then for CT.
Ultrasound of the brain, ultrasound of the pelvis.
We will go for, sir, ultrasound of the abdomen and pelvis, sir.
Very good. So what will you try to see in an ultrasound?
Sir, on ultrasound, we will try to see the type of the mass, whether it is abdominal or it is pelvic, then its size, its nature, whether it is loculated or not, the cyst wall,
Whether it is arising from the pelvis,
pelvis or
multiple tumors. Okay. Then
whether it is multiloculated or not, whether there is papillary projections, solid or echogenic areas are there. Then by the help of Doppler, we can see the
whether it is
vascular.
septa, whether it is dividing into multiple septae, what is the thickness of the septa, whether it is what. Then you talked about Doppler. Okay, then further what?
Then
Yeah, you were saying about Doppler. What is RI index? What is PI index?
pulsatility index and resistance index.
What
They will
happens
be
to them? What happens to RI and PI in an ovarian malignancy?
they will be decreased
Why?
because of neovascularity. The index will be decreased.
Okay. Okay. Now we have done it ultrasound, and then it shows that it is a mucinous cyst adenocarcinoma, and her CA-125 is raised. Along with that, her beta HCG and other tumor markers are also slightly raised. Now, and she has ascites. As you said, there is free fluid and there is a percussion, there is a dull note in the center, and she has got ascites.
Recording in progress.
Sorry. Yeah. So how will you now go ahead? You have done ultrasound, you have done, would you like to do further imaging studies?
Yes, sir. I will like to do CT abdomen and pelvis of the patient to see for the extent of the tumor, to look for any intra-abdominal metastatic lesions.
Okay, okay. So you need to go with contrast study also. What is better?
Yes.
MRI is better or CT is better?
So CT is better.
What is PET scan?
So PET scan is done if the metastatic lesions for the active metastatic lesions.
So which one is better? You recommend all the patients with ovarian tumor PET scan, or you only want
CT scan.
CT? Sorry,
CT scan. CT scan, sir.
So PET scan is not required for all ovarian tumors. Okay, so that is. Now, what is the role of FNAC, or if is there any role?
So FNAC,
or you should do some try to do a biopsy in such cases. What is your opinion on this aspect?
Sir, FNAC and biopsy are not done as they can upstage the malignancy. So we will directly go for
they cause spillage of the tumor cells into the abdominal cavity. It's the tumor. So you should never do any needling. You should never try to aspirate something. You can aspirate the ascitic fluid. You can aspirate if she has breathlessness, if she is dyspneic, and she is hypoproteinemic, she is anemia, and you need to reduce her respiratory embarrassment in that case, but do not ever put your needle into the ovarian tumor. That is very important.
Yes, sir.
Okay, now, okay, you are diagnosed it that it is epithelial or it is mucinous or a serous cyst adenocarcinoma. Okay. Now, how would you proceed?
So after all the initial investigation,
yes, Already done,
managing.
already
We
mentioned.
will, yes, sir, we will plan the patient for a staging laparotomy.
Why staging laparotomy? Why not neoadjuvant chemotherapy, which is which you can give first, and then you can give her 3 cycles, and then you can undergo a surgical intervention.
Sir, if on the preoperative findings, we will
It
we
is
think that if the tumor is non-resectable or the means the tumor is non-resectable or there is much the tumor is metastasized widely into the abdomen,
advanced
advanced tumor. In case of then we will go for neoadjuvant chemotherapy.
adjuvant chemotherapy. Otherwise, if it is a early ovarian cancer and it has not spread to the other ovary and it can be still you can proceed with a cytoreductive surgery. Then you are in a bed, and the patient should be fit
Fit
from
for the surgery.
point of view. Her creatinine level should be less than 1.2. She doesn't have any renal pathology. Her blood pressure is under control. Her diabetes is under control, and she can withstand the surgery. Okay.
Yes, sir.
In
But
that,
this is the situation. Here you will do first histopathological examination of the tumor, and then only you will start the NSPT.
okay.
Yes.
Yes, absolutely right, madam. Okay, now tell us about the exploratory laparotomy. What things you will
Yes, ma'am.
have a patient now, you are operating surgeon, you are standing on the right hand side or you are assisting the senior. How would you proceed with the
Yes.
exploratory laparotomy, and how would you do cytoreductive surgery?
Sir, in a side, we will start with the cleaning and draping, and then we will make a midline or paramidline longitudinal incision.
What is the advantage of midline over paramedium or vice versa?
So with the help of midline incision, we can explore the intra-abdominal organs. We get a space to explore the intra-abdominal organs and to look for metastasis.
What incision you have seen in your hospital when you have performed? The most of the seniors who have done
Midline incision.
midline incision. Okay. Oh, you mean to say that if you want to do an abdominal exploration or something, then you can extend the incision above the umbilicus, right?
Yes, sir.
The chances of abdominal burst abdomen are more common in midline incision or paramedian median incision. What is linea alba? Linea alba is a line which is present midline above and below the umbilicus or more
Umbilicus.
umbilicus, and it is avascular. So if you go through that line and when you again stitch less healing issues, but when you go through the right paramedian incision, you can go through a zigzag, the skin, subcute tissue, the rectus sheath, and then you lift up the rectus sheath with the alices and you come up till the midline, and then you separate the rectus muscle from the midline. Then you enter the peritoneum. So you have a Z-shape incision. You can see my hand how it goes. So when you
Yes, sir.
also, there are less chances of abdominal burst abdomen. Secondly, you can also extend the incision directly upwards rather than by making a going around the umbilicus. So,
Umbilicus.
yes, of course. If you have certain things related to the surgical aspect, sometimes it happens that you have seen that there is an ovarian tumor, but it turns out to be a gastrointestinal tumor, GIST. So you might have to keep a surgical standby, or there is a probability of omentum or intestines being stuck up, or it has ruptured ovarian tumor, or there is so it is all stuck up, plastered. So all these things you have to keep in mind, and always you have to open the the abdomen at the higher point. Okay.
Yes.
Yeah. Okay. Once you have opened, then what do you do?
Sir, then if ascites is present, we will collect the ascitic fluid for cytology.
For patient, what is there to be if? isn't it?
Yes,
Your
sir.
aside,
If it is not present, what will you do?
yes,
Ma'am, we can give peritoneal wash and then collect the fluid for cytology.
yes. And then you take a 20 cc syringe or 10 cc syringe and collect that fluid.
Fluid.
Okay. Once you have opened the abdomen, you're done. Now you see an ovarian tumor looking at you. Do you ever touch it or you don't touch it?
So we will first look for the extent of the tumor, whether it is spreading to where it is spreading, any other abnormalities, rough surfaces.
So you have to do it very gently because but some of them are having the tumor, the cyst wall. There is a break in the cyst wall. There is excrescences and there is also vascularity. They are more vascular. So even if you touch them with your fingers or you try to handle it much more, then it starts bleeding. So you have to be very careful in such situation. Of course, as you said, you need to go and try to find out the extent of the tumor, but you have to have with some gentleness. You cannot be like just taking and try to feel it and digging it out because it just goes on bleeding. If it is a malignant tumor, also the break in the capsule also occurs when you are handling. So you have to be gentle and then you also go and see the other ovary. You have to see the operability, whether it is removable, operable, inoperable, whether, and in such circumstances, you will find that the omentum is totally stuck up, where there is a breach in the capsule or there is a source of bleeding. So you will find intestines or omentum being stuck up. Have you seen such cases?
No, sir.
Yeah, okay, fine. No problem. Then what would you do now next?
So then we will, after palpating and after inspecting and palpating the intra-abdominal organs, then we will take out remove the tumor.
It is not like you press a button and the tumor comes out.
So if the tumor is limited to the ovary, then in this patient,
I understood what you meant to say. What operation you will perform in such?
sir, in this patient we will go for hysterectomy with bilateral salpingo-oophorectomy.
Yes, with what?
With
Please,
infracolic.
can you please close your slides? They are just we are living in the past. Please, can you stop sharing your? Yes, and I can't see you. Why are you hidden, young man?
Yes,
you are doing good. I can say you have got 8 out of 10 by now. Maybe madam can add 2 more points.
Yes,
Oh.
sir.
Now we see the ovarian tumor which has come in existence in front of us. So, madam, we have at least 2-3 minutes.
What do you mean by optimal?
Please, you can, yeah.
What do you mean by optimal cytoreduction?
Optimal cytoreduction means any residual. There should be less than 1 centimeter of any residual tumor in there.
Okay. Why we want to do the optimal cytoreduction in the such patient?
To reduce the chance of recurrence.
Survival benefits, for the survival benefits also.
Okay. So now you need to trace the bowel. Do you need to trace the bowel or do you need to do further additional surgery apart from TH with BSO, doctor?
Yes, sir. We will go for infracolic omentectomy. And if there are adhesions, then we have to go for that also.
Please palpate the ascending colon, the liver, the omentum, undersurface of the right and the left.
Diaphragm.
Hemidiaphragm. You need also to see the palpation of, the stomach. And finally, the transverse colon, spleen, descending colon, and the bladder and the peritoneum. This is how the systematic sequential exploration of the organ has to be done, and suspicious areas have to be
biopsies.
required. You are rightly said that you need to do an infracolic ideally. They also perform peritonectomy. It is a very important surgical procedure so that you reduce the incidence of recurrence. And such an ovarian tumor patients with with malignancy, they come back with recurrence. So it is always preferable to do a peritonectomy, and that starts from the beginning when you start opening the abdomen. Okay. And what is the role of retroperitoneal lymph node sampling? Do you do in such cases?
Yes, sir. Retroperitoneal lymph node samplings are done in early stage. It is done to see for microscopic metastasis.
Okay, now last question is about chemotherapy, just neoadjuvant chemotherapy. What would you suggest and how many cycles post-operatively you would like to give this patient in early stage and in advanced stage cancers?
So in early stage cancer, we will go for adjuvant chemotherapy, which is platinum-based. Carboplatin and paclitaxel are used 3 weekly for 6 cycles. And in cases of advanced stage, we have to go for neoadjuvant chemotherapy 3 cycles prior to cytoreduction surgery. And then we will go for interval cytoreduction, and then again 3 cycles of chemotherapy.
Very good. And what is surveillance? How will you go about surveillance when the patient becomes all right? How would you do often the surveillance of such cases?
So we will keep the follow-up of the patient 3 monthly for first 2 years. Then 6 monthly for next 3 years, and then annually thereafter. During each visit, we will go for clinical examination, CA 125 levels, and if needed, CT scan can be done.
CT scan you cannot do every 3 months. You need to do only ultrasound pelvis. Okay.
Yes, sir.
Surveillance, and apart from CA 125, if you are suspecting any other pathology, as per the microscopy which comes, then you will have to do alpha fetoprotein, HCG, LDH level, and CA 125. If it is a plain epithelial tumor, only 2 tumor markers are enough. But if it is a highly malignant or a poor prognosis tumor, as per the TNM classification, then you need to do all the tumor markers and you need to evaluate every 3 monthly and 6 monthly as you suggest. Also, they need to do a proper per rectal examination, per vaginal examination, auscultation, and if there is any history of patient having hemoptysis, or there is melena, or there is any other weight loss or any other symptoms where she has satiety issues, then we need to further evaluate her by doing even a CT thorax and CT abdomen, but we cannot do every 6 monthly.
6 months.
Right. Madam, any other question you want to ask?
Prognostic factor for the ovarian malignancy. And one second is why the fertility case ratio is more for the ovarian malignancy. There are 2 questions. And then
Ma'am, the age of the patient, the health of the patient, then the parity of the patient, then
how
the
parity
stage.
influences the prognosis? Okay, go ahead.
Then ma'am, stage of the tumor, grading of the tumor, then
Histological type of
histological type,
Okay.
then BRCA mutation, presence of BRCA mutation,
HER2 or new oncogene, presence of HER2 or new
HER2 new
oncogenes, and diploidy, aneuploidy.
diploidy, aneuploidy.
So which one is, or anything else? Cytoreduction, if it is not optimal one,
Optimal.
it also affect the survival of the patient.
Survival.
Now tell me why the fertility case ratio is more for the ovarian carcinoma? I'm not telling. Yes.
The recurrence rate is more in ovarian carcinoma, and it is rapidly growing tumor.
No. Most of the ovarian patients are diagnosed at a late stage.
Late
There is
stage
no as such pre-invasive condition as
condition.
seen in the cases of carcinoma cervix. And what other factors? There is no effective screening
Effective
method for
screening
this.
methods.
And the symptom doesn't correlate with the size of the tumor. And cancer cells, they are freely rotate in the peritoneal cavity. These are the some of the factors that increases the fatality case ratio
Fertility.
for the 5-year survival. बता सकते हो according to the stages?
According in stage 1, the 5-year survival rate is around 90%. In stage 2, it is around 80%. In stage 3, it is around 30%. And in stage 4, it is around 20%.
Third is 50 to 60 and fourth is 17, 20 around
20
just
to 30.
30.
Overall 45%.
What are the newer modalities apart from the surgery and the chemotherapy? What
Yes,
are the
ma'am.
other newer modalities for the, what are the new additions in the ovarian malignancy management? Newer drugs.
We can add bevacizumab, which are targeted therapy, human monoclonal antibodies. They can increase the survival rate. Further, we can use polyadenophosphatase ribosyl inhibitor, like olaparib and rucaparib.
Okay. And immunotherapy and the gene therapy. Okay. And what is your opinion regarding the genetic testing in all the ovarian cancer patients?
Genetic testing should be done in all the patients who are diagnosed with epithelial carcinomas.
Why?
Epithelial ovarian carcinoma.
Why? Because around 40% of the BRCA-associated ovarian cancers, they are not having the family history. We only assess the family history and then we go for the, we think
Genetic
for the
testing.
hereditary cancer actually. No? But in 40% of the cases, we don't have such type of history. Yes. Over from my side, sir.
Yeah. So I think I think you have come out with very flying colors and really appreciate all the answers you've done.
Yes, yes.
Thank you, sir.
And you are to pursue fellowship in gynae oncology in India. If you are really interested, because it's a very important subject. Still, there are
yes.
who are dying of ovarian cancer. It's a fourth important cause of death, of mortality in young, in our women, especially in postmenopausal, and I have seen also in quite early reproductive ages also. So मला खूप बरं वाटलं आज नागपूरला मी आलो आणि डॉक्टर सुषमा आणि त्यांचे सहकारी डॉक्टर सेक्रेटरी मॅडम
Pragati.
and also Priyanka. Then there is many of them. Prachi Dikshit, I can see. Mukesh Bang sir is going to take a lecture, and it was really nice. I think Sushma madam, I missed you in Figo.
Yes, I couldn't come. Yeah.
But,
actually, I couldn't come because my conference is there. Carnival is supposed to be Carnival, so I'm busy with so many preparations, and other things are also there.
Every year you do Carnival, but we missed you in the fashion show of the Paris and Milan and then Switzerland. But I'm sure your Carnival is more important as how Bollywood is important for Mumbai, and I'm sure you have made a name in not only India but also in other countries.
Yeah, 4 international faculties are coming actually.
Yes, madam. I know your enthusiasm, and I am really happy to see my colleague, Dr. Nikit, right?
Yes, Nikita, sir. Nikita Vijay.
Nikita.
But you are both a really fantastic examiner, and Abhijit, you are a very good student. I was listening really, so it was wonderful. Everything was going so nicely, and so practical points you were telling.
Yes, and I think that's more important. And It is really, I'm feeling very happy. I have made some slides. If you permit me, I will forward to the president
Sure,
and
sure.
for their benefit, because I have one student, Dr. Shraddha Rao. She met
Yes,
me this
sir.
morning. She has done from NKP Salve.
Yes, sir. She is our student, sir.
Yes,
Shraddha Rao.
yes, and she told me, sir, that your lecture is there and it is there also in the group, and we attend it on Thursdays, first and third Thursdays every month. And I said now all our Mumbai student and also Navi Mumbai Thana student, I have told all of them in our groups also that they are now not only attend our PG crash course which we take annually and the EFG RAN symposium, but Dr. Sushma, now we are also going to attend your Thursday clinics.
Thank you. Thank you very much.
Of postgraduate star, and I am
Yeah.
really very happy that
Every time really we are getting very good response of PG students.
yes, madam,
And
and
they start asking when is the next one, like this is the first and the third Thursday.
so it is very important as consultants and as teachers that we encourage our students, and we are very happy and proud that all of you are doing very well, and I wish all the best to all of you. Thank you so much.
Yeah.
And
We'll have one photograph.
yes, but
Corona people, please, everyone is there. Please open your windows. We'll have a one group photograph.
Sheesh sir, Tanushree ma'am, please join.
Dr. Tanushree, Dr. Ashish Zararia.
Tanushree,
Hello ma'am. Hello Mukesh sir.
Hello.
Yeah.
Hello.
I think
Welcome,
I'll
welcome,
give
Dr.
100%.
Mukesh.
Thank you, Sushma madam. Thank you, everyone. I think I'm giving 100% to Abhijit because he used bevacizumab properly. He used the word name properly. I think more than that, I'm giving him 100% marks for it. So,
See, Abhijit, everyone is appreciating you.
Thank you.
you
Good one, beta.
Abhijit, well done, and it's really wonderful hearing you, and experts were mind blowing. I mean, I just had, I just could hear the half part of it, but it was really, really very fruitful and very beautifully conducted.
Thank you, sir. Thank you so much.
Corona people, done? Vashishta, who is there?
Achha.
Ruchir is there, na? Ruchir
He's mute.
is there?
Yes, ma'am. I have already taken and put it in the group.
Okay.
Thank you so much.
Everybody is smiling now constantly when you are saying.
Priyanka.
Yes, ma'am.
I think you take
Thank you, Niranjan.
Hi,
sir,
Thank you,
and,
Dr.
Thank you so
Niranjan,
much. Thank
for
you so
being
much.
here. Thank you. Thanks a lot.
Thank you, ma'am. Thank you so
We'd
much.
like to have you again and again.
yes,
It
yes,
was
I'll
wonderful.
come.
Yeah.
I'll come every 2 months, 1 month. I
Next
love.
time as a
Thank you
speaker,
so much, sir.
okay? Next time as a speaker.
Thank you so much.
Okay. Thank you, Niranjan sir and Nikita ma'am, that we had very informative, knowledgeable discussion. And as usual, sir had given her 8 out of 10 marks, so I need to ask her
Two
appreciation.
from my side. 10. 10 out
10,
of 10.
10 out of 10.
Thank you.
Thank you, ma'am. Now, without wasting again our time, we will move our second section, that is on ovarian cancer, how to treat and update.
so I think I am the only physician medical oncologist sitting here along with all of you surgeons. So if surgical part, I think you know better than me. I'm the one who is going to tell you about the medical part. I'll not go into brief about the basic introduction, which everyone knows, and second most common gynae cancer, most common gynae cancer related death, fifth leading cause, and everything you know, and the questions are already done. So the lifetime risk of developing ovarian cancer is 1.3%. 1 in 80 women will be diagnosed with ovarian cancer. Risk factors, I think sir and madam has already taken a dig with Abhijit and asked everything. So the important part which he asked to Abhijit was BRCA testing. The red flags for cancer susceptibility is a BRCA 1 and 2. The important factors are multiple family members with ovarian or breast cancer, age of onset of breast cancer younger than 50 years of age, premenopausal, bilateral breast cancer, both breast and ovarian cancer, Ashkenazi Jewish ancestry, and male breast cancer. There are some other factors also, but these are the important red flags for checking the BRCA testing. So what is the lifetime risk of cancers? It is not only BRCA 1 and 2, it is also MMR, because in endometrial CA there is a importance of MMR, and nowadays the guideline has shown to use immunotherapy if there is a DMMR, like deficient MMR is there in the endometrial CA. You can directly use immunotherapy in these cases. So now in all these genitourinary malignancies, we always do gynecological malignancies, we always do BRCA1, BRCA2, and MMR testing. So this is one important point here. So FIGO staging already all of you know, I think better than me. In short, for the PG students,
can we just ask chairperson to just introduce chairpersons of the today's session, your session, before starting your...
Yes. I think that part was left, but Mukesh has Mukesh has
Ashish
started,
Harari
and
and
I
Dr.
think
Tanushree are there. So
chairpersons are very important. I myself introduced both of them. So one is Dr.
Please,
Ashish Harari. I know him very well.
Favor, 1 minute. Priyanka, Dr.
Yes,
Priyanka,
ma'am.
please just introduce chairpersons.
Yes, ma'am. Our chairpersons are Dr. Ashish Zararia, sir. Sir is associate professor at GMC Nagpur. Sir having more than 20 publications at national and international level. Sir is a member of advisory committee to Ministry of Health and Family Welfare, Government of India, for developing and expanding obstetric ICU and HDU facilities all over the India. Now our second chairperson is Dr. Tanushree Jain, ma'am. Ma'am is currently working as NCI Nagpur. Ma'am having her specialty in oncogynecology. Ma'am is very much academic and interested in her oncosurgeries, and she is also too much interested in her oncofertility also. So now I would like to request Ashish sir to introduce Mukesh Bang, sir.
Yes.
Slides also just... can you just here to just stop sharing your slide so they will share their slides.
Yes.
So it's my pleasure to introduce Mukesh Bang to all of you. He's a great friend of mine, and he works at Alexis Hospital as well as nearby GMC, our own cancer hospital. And he's an intensivist also, and he was awarded the best oncologist of Maharashtra in 2021. So that's so creditable, Mukesh. And I hope OBGYN will be benefited with your inputs. So over to you, Mukesh.
Thank you.
You can start
I
now.
think I start. So can I go ahead with this slide only now? So
yes, Mukesh,
sure.
please. You can start from wherever you left. Yes.
Thank you very much. So the basic about staging is not to complicate ourselves. Stage 1, tumor limited to one or both ovaries. Stage 2, tumor involves one or both ovaries with disease confined to pelvis. Stage 3, tumor spread outside the pelvis to the peritoneal cavity or lymph nodes. And stage 4 is the distant metastasis. So why it is important to have a histological subtyping? Because the cellular origin varies among ovarian cancer subtype. As you can see in the slide, if there is surface epithelial, then you have a high-grade serous carcinoma, low-grade serous carcinoma. And if it is endometriosis related, then you have a endometrial carcinoma or clear cell carcinoma. Or if you have an endocervicosis type, then you have a mucinous carcinoma. That's the reason the subtyping of ovarian cancer is important, because there is a prognostication to it. As you can see in the slide, the PFS and OS, that is the progression-free survival and overall survival, are lower in mucinous or clear cell histology than serous or endometrioid ovarian cancer. That's the reason we always suggest to do a biopsy, not to treat any patient based on only FNSE. Sometimes we see the report that the fluid is positive for malignant cells, or fluid is positive for cancer cells or atypical cells, and the consultant starts with chemotherapy or surgery. It is not like that. The subtyping of the ovarian malignancy is very important, because the survival benefit and the treatment protocol changes with each malignancy subtypes. So what is the initial management? Basically, the most important part in ovarian cancer is with the gynae-oncologist. When the woman presents with ovarian cancer-related symptoms, history examination, which we already discussed, and when we suspect it's ovarian malignancy, we try to do first clinical examination, ultrasonography, CA-125 imaging, as we discussed in the previous session about CT scan and PET scan, and then automatically PET scan for the metastatic workup. And the first patient, my first choice is always send the patient to gynae-oncologist. Let him or her evaluate and let them give me the call whether they can do optimal cytoreduction or not. So if there is no risk assessment, then automatically we do average risk of ovarian cancer screening. And if we feel there is a family history or personal history, then automatically you should not do directly BRCA testing. You should do genetic counseling first before sending for the BRCA or genetic testing. See, it is very important. Nowadays, we talk about sending the samples, but once it comes positive, all family gets shattered. So automatically genetic counseling is very important before doing any genetic testing. As already discussed in the previous session, so when we have a suspicious palpable mass or floating in the abdomen, we do usual initial evaluation, as already sir has told, and based on clinical stages, we decide. As Nikita madam was asking, the fertility desired 1A, 1B, automatically we do the salpingo-oophorectomy plus comprehensive staging. In stage 1A to 4, surgical candidate, optimal cytoreduction is likely. Automatically, we want gynae-oncologist to come in a picture and do the surgery. Only the picture for us as a medical oncologist is if the patient have a poor surgical, if the patient is a poor surgical candidate, or if the gyneco-oncologist is saying that it's less likely that they can go for optimal cytoreduction, there the role of neoadjuvant chemotherapy comes. So one more scenario, many times working in a tertiary care center, we find sometimes the patient has been operated outside with some mass removed, and then it turned out to be ovarian cancer or a malignancy proven histopathology. Then we automatically ask the gyneco-oncologist again to check for all the markers and scanning, and we always want them to do surgical staging considering the previous scenario. So this is what is the principle of surgery. I think you people know better than me, but what the guideline, NCCN guideline says, if the patient is a newly diagnosed invasive ovarian cancer confined to ovary, on entering the abdomen, aspiration of ascites or peritoneal lava should be done for peritoneal cytological examination, and all peritoneal surfaces should be visualized, and the biopsies should be done, and the BSO hysterectomy should be performed, infracolic omentectomy should be done, paraortic lymph node dissection should be done in early stages. And the main important point is the preferred method of dissecting pelvic lymph nodes is bilateral removal of lymph nodes overlying and anterior to the common iliac vessels, overlying and medial to the external iliac vessels, overlying and medial to the hypogastric vessels, and from the obturator fossa as the minimum anterior to the obturator. Now, this is I think you people know, but this is one point for me it was more, so that's the reason I am telling this point. So the primary treatment. So as we discussed before, the primary treatment automatically is the surgery. Depending upon the stage, fertility desire, we decide for the surgical part. And if the patient is having bulky disease or poor surgical candidate, then patient is referred to us for the neoadjuvant chemotherapy. Sorry. So maximum surgical debulking and platinum chemotherapy is the cornerstone of primary treatment. Aim of surgery to confirm diagnosis, define extent of disease spread, and resect all visible tissue. As Abhijit was telling, what is optimal cytoreduction? Previously, it was less than 1 centimeter, but now it is no microscopic visible disease should be there. So there was a recent randomized trial which investigated whether initial diagnostic laparoscopy could prevent futile primary cytoreductive surgery by identifying patients with advanced ovarian cancer who cannot be optimally debulked. So 10% of the patient in the diagnostic laparoscopy group had futile laparotomy versus 39% of the patients in the primary cytoreductive surgery. That means if you have a doubt about optimal cytoreduction, it is better to do diagnostic laparoscopy and see whether you can consider for neoadjuvant chemotherapy and then consider for interval cytoreduction. Bevacizumab plus chemotherapy followed by single agent bevacizumab is recently approved for upfront treatment of ovarian cancer. So stages we already discussed about. Cytoreduction goal. Why we need? Nikita madam already asked the same question. Why we want optimal cytoreduction? Because automatically it improves the overall survival. You can see here, if the residual disease is more than 10 mm, the overall survival is 17 months. If it is 1 to 10 mm, 32 months. And if there is a complete cytoreduction, it goes to 56 months, like 3 to 4 years. So definitely optimal cytoreduction is a goal which we want. The second question which the examiner asked to Abhijit was, what is the role of lymphadenectomy? I think you surgeon know better. I think Tanushri also can elaborate on this. Lymphadenectomy in resected lymph node negative advanced ovarian cancer. In patients with advanced ovarian cancer, upfront surgery achieving macroscopic complete cytoreduction is a part of curative treatment standard of care. Randomized trial of systemic pelvic and parotid lymphadenopathy demonstrated significant improvement in progression-free survival, but not overall survival in patients with little or no residual disease. So the current prospective randomized trial, Lion trial, investigated the PFS and OF benefit of lymph node dissection in patients with, you remember this, in patients with lymph node negative, clinically, radiologically, advanced ovarian cancer following macroscopic complete resection. So this is a Lion study where the criteria was adult patients with suspected or proven stage 2B to 4 epithelial ovarian cancer, macroscopic complete resection, and clinically and radiologically negative pelvic and parotid lymph nodes. So whether to do lymphadenectomy or not. So the conclusion was, in patients with advanced ovarian cancer, the median OS was 67.2 months, 5-year overall survival was 55.9%, and median PFS was 22.5 months. So the conclusion was, the systemic lymph node dissection not recommended in this patient population if there is clinically and radiologically no lymphadenopathy in advanced ovarian cancer. So let's come to the my part of this area now. So it's simple to remember for the PG students. If there is a stage 1A, 1B, grade 1, no need of chemotherapy. Grade 2 endometrioid, high grade serous carcinoma, any other histopathology, you need a chemotherapy. Previously, there was a data of using 3 cycles of adjuvant chemotherapy in early stage tumors. But nowadays, we always prefer to use 6 cycles of adjuvant chemotherapy, which involves paclitaxel and carboplatin. So you can see here, stage 1A, 1B, excluding grade 1, grade 2 endometrioid, grade 3 endometrioid, any high grade serous carcinoma, you need to give chemotherapy. And stage 1C onward, automatically you need to give chemotherapy. So 1A, 1B, grade 1, no chemotherapy other than all other areas, you need to give adjuvant chemotherapy. So the chemotherapy definitely has evolved from last many years. Previously, it was adriamycin, cyclophosphamide, different drugs combination were used. Then the first important drug combination was cisplatin and paclitaxel 24-hour infusion. And that cisplatin paclitaxel improved overall survival of the patient. Later, it turned to 3-hour infusion of cisplatin and paclitaxel. Automatically, it has also improved the overall survival. Now, based on GOG trials, now we have carboplatin and paclitaxel as a standard drug of choice with a minimum side effect as an adjuvant and in metastatic setting ovarian cancer. So now again we go back to the area where neoadjuvant therapy is involved. So gyneco-oncologist has seen the patient and they told that it's a poor surgical candidate for optimal cytoreduction. So automatically patient comes to me for neoadjuvant chemotherapy. In all ovarian malignancy, epithelial ovarian malignancy, we do germline testing. The difference between germline and somatic, germline you can do on the blood, somatic you have to do on the tissue. So automatically we do neoadjuvant chemotherapy followed by response assessment and then decide for interval cytoreduction and adjuvant therapy. So the question again asked to Abhijit was, this slide is important for the PG students. The current indications of neoadjuvant chemotherapy in ovarian cancer. First of all, for me as a medical oncologist, the gynae-oncologist has said, okay, you go for neoadjuvant. That is the first indication for me. So otherwise, the theoretical purpose, poor performance status, medical condition, optimal cytoreduction is less likely. The CT findings with diaphragmatic disease more than 2 cm, extraperitoneal disease like lung or brain metastasis, multiple liver metastasis, involvement of portohepatitis, pancreatic head and body metastasis, suprarenal parotic lymphadenopathy. So these are few of the CT imaging findings which tell us to go for neoadjuvant chemotherapy than directly going for primary cytoreductive surgery. So this also has been quoted in EORTC and CHORUS trial, but the final conclusion, what they have quoted, you can see here. EORTC exploratory analysis showed that primary surgery benefited in stage 3C patients with metastatic tumors less than 45 mm size, and neoadjuvant chemotherapy benefited in stage 4 patients with metastatic tumor more than 45 mm size. So, and JCOG also has shown the non-inferiority of neoadjuvant chemotherapy followed by interval debulking surgery to primary debulking surgery followed by chemotherapy. So both this trial have quoted that if the poor performance status and what the previous criteria I told, you should go for neoadjuvant chemotherapy followed by surgery. So the guidelines, as we just now I told, if there is a recommendation for neoadjuvant chemotherapy, you should go for neoadjuvant therapy, and then that you have to decide based on the patient performance status, you have to decide for the chemotherapy backbone and then give 3 to 4 cycles of neoadjuvant chemotherapy followed by cycles, because now cycles sometimes you can go up to 6 cycles if the patient has a good response. But usually in our practice, we try to give 3 to 4 cycles and then hand over to the gynae team to process for interval cytoreductive surgery. So drug reaction, I think this is not much important for you, but because the platinum drugs are very notorious to cause infusion reactions and allergic reactions, so we have a protocol recommendation how to treat these infusion reactions. These are very common with platinum. That is the reason we always give steroids along with all antihistaminics, and we have to be very careful when you use platinum drugs to the patients. So the high level overview of frontline treatment. So this is again a revision: surgical candidate and high likelihood of surgery, surgeon. Then chemotherapy, genetic evaluation. Then comes maintenance therapy. This I will be discussing later. And if the patient is a poor surgical candidate, neoadjuvant chemotherapy, 3 to, as I told, 3 to 4 cycles, and then surgical debulking, and then adjuvant therapy. So now we have come in oncology, like all malignancies, we are trying to see whether we can keep it as a maintenance therapy and we can make it this disease as a chronic and a curative disease, just like a prostate cancer. Even if it's a stage 4 prostate cancer, we have a treatment which can keep the patient for 5, 7, 10, 8 years. Now in breast cancer, if hormone positive breast cancers are there, we have patients who are on 7, 8 years of therapy, even if it is a stage 4 disease. Like that, we are trying to see in ovarian cancer. Automatically, there are multiple lines of therapy in ovarian cancer, and usually we try to push the patient even in stage 4 for 3 or 4 years with the various treatment options available, like primary cytoreduction, interval cytoreduction, secondary cytoreduction. We have different chemotherapy options. We have targeted therapy options. We have PARP inhibitors. So many things we have. So now similar thing we are doing in ovarian cancer. See, we have done an optimal cytoreduction chemotherapy. The 2 points are there, either to observe the patient or to give the maintenance therapy. If you observe the patient, automatically we know the patient will relapse. But if you give a maintenance therapy to this patient, there will be a slow growth and the minimal detectable threshold will be there, and so that we can prolong the relapse of the patient. That's the reason in now all malignancies in stage 4 diseases, we are trying to keep some or the other maintenance therapy so that to prolong the relapse of the disease. So what are the advent of maintenance therapy? The previously it was paclitaxel used to continue as a maintenance, but it patient couldn't tolerate. Then started with bevacizumab. That is the first line. Now it is approved in the first line, neoadjuvant, adjuvant, and metastatic setting, and as a maintenance drug. Then it is followed by olaparib. This is a PARP inhibitor, and again the treatment evolved. Then come niraparib, then rucaparib, and again there are different data of using first line BRCA mutation, which started from 2018 as per the solo data of using olaparib as a maintenance therapy in first line metastatic ovarian cancer. So now I told you, see, previously we were happy with this combination of paclitaxel cisplatin. Then the combination came with paclitaxel. We were happy this combination is working. Now we have a triplet combination of using paclitaxel, carboplatin, and targeted therapy. Anything you can choose, either bevacizumab or PARP inhibitor. So now, right now, with the present situation, we are happy with this combination. So, but as the time goes, we know there will be new and new modality of treatment which will come in a picture and which will help us and guide us and add more treatment to the present combination of chemotherapies and targeted therapies. Now immunotherapy is there. Now other PARP inhibitors are there. Other tumor markers are there. And so that's the reason we have different targeted therapies available now. So as I told, bevacizumab is added to the frontline therapy in GOG trials. I'll not say about trials here because it is too much of trial for other people than medical oncologists. So based on the different trials, bevacizumab is added as a frontline therapy and it continued as a maintenance therapy, which improves the progression-free survival. So the PARP inhibitors. So the PARP inhibitors have 50 years on from PARP inhibitor discovery. You can see from 1960s it has started, and then evolution was there. Initially it was for breast cancer, and then further progression happened more in ovarian cancer, and now it is approved as a first-line maintenance therapy. People may be asking why not, if the BRCA positive is there, why not we can start from with chemotherapy? But if we add with chemotherapy, it gives too much of toxicity. If someone has used PARP inhibitor, they will understand what I am saying, because these PARP inhibitors cause pancytopenia. They drop too much of hemoglobin, WBC, platelets. Even the dose of 300 milligram BD of olaparib, it is very difficult to tolerate by the patient. So automatically we start with a lesser dose and we try to see whether the patient will tolerate or not. So we have come across these PARP inhibitors are a wonderful drug. I have few of my patients who are on PARP inhibitors. They are doing well. I have one of my known gynecologist, I cannot name, but she was treated with all treatment and she came BRCA positive. She has finished 2 years of olaparib, and now since 2021, she is fine and she is not on treatment and absolutely fine. So definitely these drugs works. And I know sometimes the other people say, medical oncologists say fancy thing, import very high class drugs, very costly drugs. But when we see all these results now, automatically we always want these drugs to be used in practice and to see. So approximate 50% of high-grade serous ovarian cancer have alteration in HR repair genes. So these are different genes. So what we talk about HR deficient, possibly HR deficient, HR proficient, and other. So definitely in this scenario, definitely the PARP inhibitor works. So HR deficient and possibly HR deficient. So how we check it? So nowadays we have HRD panel, that is homologous recombinant deficiency panel. Sometimes there is a confusion, what is BRCA, what is HRR, and what is HRD. See, BRCA is divided into germline and somatic. Germline means it can be done from your blood. Somatic you have to do from the tissue. That is a basic BRCA gene. That is only single 2 genes we check. The HRR gene tests your mutations, pathologic mutations in the HRR genes. But the HRD panel takes care of your genomic aberrations also. So that's the reason HRD includes your HRR also and your BRCA also. So if the patient doesn't have a cost issue, definitely HRD, we always suggest HRD panel for all ovarian malignancies, serous ovarian malignancy. I'll show you one report also. This is one of my patients who had low-grade serous cystadenocarcinoma involving ovary. You can see here the BRCA mutation is negative, but the patient is HRD positive. So now a guideline has suggested to use PARP inhibitor if the patient is HRD positive, even if BRCA is negative. Why? I will go back here. You can see, even if the BRCA is there, even if it is negative, there are some other gene mutations which can be targeted with PARP inhibitors. That's the reason, even if BRCA is negative, but HRD panel is positive, you should consider PARP inhibitors. And nowadays, the cost of PARP inhibitor has gone down from 1.5 lakh to 50-60,000 per month. So now at least a few of the people are affording and using the PARP inhibitors. So the evolutionary milestone, I will not go into the trials. As I told already, bevacizumab followed by olaparib. Now there is a data of using olaparib along with bevacizumab as a maintenance therapy if we have used bevacizumab as the first line the treatment option along with paclitaxel. So what is the final proposed systemic algorithm So you test for somatic of germline BRCA, and then you decide for neoadjuvant chemotherapy versus primary debulking surgery, and then you decide about addition of bevacizumab to paclitaxel, and then addition of PARP inhibitors. So automatically you can see the sequence here: surgery, chemotherapy, addition of bevacizumab required or not. Why it is important? See, in my practice, I don't use bevacizumab in neoadjuvant setting because first 2 cycles you use. Third cycle again you have to stop because the surgeons will be taking care of the surgery, and bevacizumab is contraindicated because you cannot do surgery 6 weeks before stopping of bevacizumab, because it is a vascular endothelial growth factor inhibitor. So automatically it causes bleeding. So bevacizumab has to be stopped 6 weeks before planning for surgery. So automatically you are missing the third cycle. After surgery, again 4th cycle you cannot use, then you have to use in the 5th and 6th cycle. So automatically where there is intention of interval cytoreductive surgery, you should avoid using bevacizumab. Once surgery is done, whether it is the R1 dissection or whatever, then after 5th or 6th cycle, you can consider using bevacizumab and continue as a maintenance drug. And based on your germline and BRCA or HRD panel, you can add PARP inhibitors. So genetic testing, current guideline. What are the current guidelines? So as I already told, germline testing for BRCA1 and BRCA2 recommended for all women at diagnosis, regardless of family history of ovarian or breast cancer. If the patient is an ovarian malignancy, serous epithelial ovarian malignancy, you should do BRCA testing. Somatic testing also. Then clear cell mucinous or endometrioid ovarian cancer, the other tumor marker like DMMR should be checked because there is a target for it now as immunotherapy. So now you can see here, the NCCN guidelines are difficult to understand for the other people. So I'll go by the flow chart. So you see here, the patient is diagnosed with treatment, diagnosed with ovarian malignancy stage 2 to 4, treatment done. Whether bevacizumab or used or not, if not used, you check the BRCA. If BRCA is wild type and there is a complete response, there is a still data of using niraparib as a maintenance therapy. If germline BRCA mutation is positive, even if the patient is CR or PR, you can still consider olaparib as a maintenance therapy in ovarian cancer if germline mutation is positive. If we have used bevacizumab as a primary treatment along with chemotherapy, if BRCA is negative and proficient, you can continue only bevacizumab. And if germline or somatic BRCA mutations are positive, you should consider bevacizumab along with olaparib. And there is a very good data of this combination. And I have patients and they are doing well. So definitely this combination is working and doing well. So what are the current treatment options? These are the various treatment options. I will not go into detail for the PG students or for other people. I think paclitaxel, carboplatin, gemcitabine, and lipodoc. These are the important drug combination which everyone should know. The targeted therapy, as I told, bevacizumab, olaparib, rucaparib, niraparib, pembrolizumab, as I told, for MSI or DMMR positive patients. So the NCCN guideline has again mentioned the different chemotherapy regimen. For mucinous carcinoma, definitely we try to prefer the colonic regimen, but it's not like that every time we use colonic. We can use paclitaxel, but colonic being a mucinous carcinoma, we prefer to use a colonic regimen there. Otherwise, in all other malignancies, paclitaxel is a standard backbone chemotherapy regimen. So what is the follow-up recommendation? As the sir was mentioning, examiner sir was mentioning, the follow-up physical examination every 2 to 4 months for 2 years, and then 3 to 6 months for 3 years, and then annually. Physical plus pelvic examination. As sir was telling, every time there is no need of CT scan, you can just do CA 125 markers, CBC, and the other chemistry profile, SOS if required, sonography. And if there is a doubt, then you can consider for CT scans. So final comes to the ASCO guidelines. What are the ASCO guidelines are telling about all this? See, we have come to the conclusion. We have finished with our part of ovarian malignancy. We have started with neoadjuvant cytoreduction surgery is done by the gynecologist, adjuvant chemotherapy received, and patient is on bevacizumab and she came BRCA positive. So I have started her on bevacizumab plus olaparib as a maintenance therapy. That's all. So that is the completion treatment plan for ovarian malignancy. Now, what are the recommendations? What the recommendation, ASCO recommendation says? The question first was given by these questions were given by the gynae oncologist or gynecologist basically to the ASCO team. So what clinical evaluation should be performed in all women with suspected or newly diagnosed stage 3, C or 4? The recommendations were should be evaluated by gynae-oncologist prior to initiation of therapy to determine whether they are candidate for PCOS. This was I was telling. For me, ovarian cancer. First, I will call gynae-oncologist, tell, can you see this patient? And what is your take on this? Whether you can do primary cytotoxic surgery or not. If the surgeon says, okay, I can do primary cytotoxic, I am happy. I am more than happy. So my load is less. The second recommendation is a primary clinical evaluation should include a CT scan of the abdomen and pelvis with oral and intravenous contrast, and chest imaging should be done. See, many times I see people, the surgeons, they do only CT abdomen, but they forget to do CT chest. In ovarian malignancy, the pleural fluid positivity changes the stage. So you should always check, always do chest imaging to assess the staging and for the surgical resection. So the second question is which patient and disease factors should be utilized as criteria for identifying patients who are not suitable for primary cytoreductive surgery. This we discuss. So the recommendation says women who have high perioperative risk profile or low likelihood of achieving cytoreductive to less than 1 centimeter, ideally to no visible disease. This I was telling. Ideally now it is no microscopic visible disease should receive neoadjuvant chemotherapy. So how do neoadjuvant chemotherapy and PCS compare with respect to progression-free survival, overall survival, and perioperative morbidity and mortality in women with newly diagnosed stage 3C or 4 epithelial ovarian cancer who are fit for a primary cytoreduction and have potential resectable disease? So for women who are fit for PCS with potential resectable disease, either neoadjuvant chemotherapy or PCS may be offered based on data from phase 3 RCTs that demonstrate that neoadjuvant chemotherapy is non-inferior to PCS with respect to progression-free survival and overall survival. The main factor of neoadjuvant chemotherapy is associated with less peri and post-operative morbidity and mortality and shorter hospitalization. But PCS may offer superior survival in selected patients. So here, as we discussed before, neoadjuvant criteria we should remember and we should see, and then accordingly we should decide whether neoadjuvant chemotherapy or primary cytoreductive surgery. So I'll go to the question 4. Clinical evaluation. This we already discussed. Preferred chemotherapy regimen, as already told, paclitaxel and carboplatin. Does the timing of interval cytoreduction or the number of chemotherapy cycles after interval cytoreduction affect the safety or efficacy of the treatment? RCT is tested surgery followed by 3 or 4 cycles of chemotherapy is women who had a response to neoadjuvant chemotherapy or stable disease. As I was telling, there are 3 or 4 cycles. Interval cytoreduction surgery should be performed after less than or 4 cycles of neoadjuvant chemotherapy with women who have response to chemotherapy or stable disease. So, what are the treatment options for patients with progressive disease or neoadjuvant chemotherapy? Then automatically we know that they have a poor prognosis, and then we have to use the refractory regimens, alternative chemotherapy regimen. Either we have to do the molecular profiling to see whether we are missing something molecular target and put the patient on clinical trial. So at the end, the summary of ovarian cancer in a brief way is: in early stage, surgery followed by adjuvant chemotherapy as per histology. Stage 2 to 4 surgery, excluding patient for neoadjuvant chemotherapy. Excluding stage 1A and 1B grade 1 endometrioid, adjuvant chemotherapy is for all with paclitaxel and carboplatin for 6 cycles. Query role of lymphadenectomy in advanced disease if nodes are not involved radiologically or clinically. Stage 3 to 4, maintenance therapy with bevacizumab and or PARP inhibitor depending upon the BRCA mutations. And now we always do biomarker testing including BRCA, MSI to be checked in all patients with ovarian cancer. So now previously we know we were happy with Brahmastra 1, it has a huge way and we were happy, very much happy, but we always want more and more. In oncology, we have learned one thing: this is less, we want more. This is less, we want more. Just like after Brahmastra 1, we want now Brahmastra Part 2. Similarly, we want more and more drugs to see whether we can cure and we can increase the survival of the patient. Same thing is happening with ovarian cancer. Now we have immunotherapy as a neoadjuvant pembrolizumab in all solid malignancy if the patient is MSI high or dMMR. So in all dMMR or MSI high patients, you can consider neoadjuvant pembrolizumab and see the response. So now that's the reason in all malignancies, we should do MSI testing to see whether we can consider neoadjuvant pembrolizumab. This is very fancy to say immunotherapy, but it has its own cost because it costs near about 1.5 to 2 lakh, even if the PAP program we use, and not all patients are affordable for pembrolizumab. That's the reason sometimes we don't do MSI if the patient is not affordable. But treatment guideline always suggests to do MSI testing in all solid malignancies to consider for neoadjuvant pembrolizumab. But this is a very costly drug. But I have few patients on pembrolizumab and they are doing well. So for that, so sometimes I work for a large multinational. We are looking for a world-class expert in digital. This is what the people, patients, people or the person says. So then I say, I am your man, but I am not cheap because some drugs are very costly drugs. Like if you talk about bevacizumab, olaparib, pembrolizumab, these are very costly drugs, and definitely they are included. These drugs are included in the basic treatment portfolio of ovarian cancer. So thank you very much. The best thing in life are actually really expensive. Thank you very much.
Thank you, Mukesh sir, for such a valuable talks on a topic of management of ovarian tumor. Now, I will hand it over to Dr. Tanushri Jain ma'am to conclude the session.
So, Mukesh, I would say this was a really very comprehensive presentation, and I really enjoyed it for the simple reason that even being a medical oncologist, you realize the importance of surgery in ovarian cancer. So that is one point I really appreciate. I would just like to add upon here that whatever trials which showed equal survival in NACT versus primary, they are basically all for 3C4, which we conveniently forget. Ascites, peritoneal disease, and the straightway the patient goes for neoadjuvant. So that is something I would like to press upon for the students. Hereditary point is very important for our patients. But I would like to ask you, I understand the complete importance of BRCA, but do you think MMR has got so much of significance, at least for time being, in ovary as compared to endometrial? I mean, in endometrium, we have a very clear-cut benefit. We are going for all patients. But ovary, I think we need to wait because it's a very small percentage, I think, would come up with that MMR deficiency.
Yes, I'll tell you, I have an example of one colonic patient. See, MMR guideline came for colonic also. I think in 2019 or 18 or 19 somewhere. We checked one of the patient at that time, and we told that, see, you have finished first line of therapy, and he had a metastatic disease including lung, liver, and the primary disease. And the patient, I explained him that, see, now this is the target we have, and if you don't have a cost issue, you can start with pembrolizumab. Yes. At that time, when the guidelines were not there, and I started with the third line, fourth line setting, they were saying if you don't have any option, you use this. But the patient is still alive, and patient took 2 years of pembrolizumab. So similarly, what we have realized.
I'm not talking about guidelines, but what I want to stress here is that 60% of colonic, 40% of endometrial, and 6 to 15% of ovary. So that is the difference. Right. Probably
wherever we have.
Whenever you get a target, yes. I appreciate. But when we are not doing the basic BRCA testing, I think that is another second step. Yeah.
Yes.
That is what we need to stress upon, to at least do BRCA and HRR. Then we can definitely go to that. I agree to your point. Also, I would
nowadays MMR also done in 3 or 4,000, 5,000 only.
Yes, so we are doing it for all endometrium. Definitely, yes. Definitely. I agree to your point. I also want you to highlight here that for low-grade, borderline, and mucinous tumors, don't you think that chemotherapy, we know they are mainly chemorefractory tumors, and we many times don't consider them as seriously as
definitely.
Because we think these are low-grade and borderline. So why to worry? But when they come with advanced, this is like I get so many stage 3 borderlines. I mean, this is something that. So I think as organic residents should understand the importance of these tumors, because they are not going to be chemo responsive. So only surgery is going to help, and that can involve anything, starting from peritonectomy to bowel resection, because that is only going to work. Because even if I had a splenic mass tumor with a low grade tumor, so that can happen. Fourth thing, I'm not such a fan of bevacizumab. Of course, you can understand as a surgeon, it causes a lot of difficulty.
That's the reason I gave 100% marks to Abhijit.
You get, but I would didn't. But one thing is for sure, it's got a PFS benefit, but no OS benefit.
See, in all malignancies, not in ovarian, in all malignancies, I have seen bevacizumab. If you see all trials in all malignancies, it gives benefit of 4 to 6 months, not more than that. That is a PFS.
Yeah, but quality of life matters. So I agree to your point.
That's the reason we give.
Okay. You rightly pointed out the LION trial. Before we go to it, I would also like to stress upon that one thing that organic residents also should understand, that para-aortic lymph nodes are the primary nodal basin for ovary and not pelvic. So many times I see that pelvic lymphadenectomy is done and not para-aortic. So for early stage, 30% of high-grade serous can have pelvic and para-aortic nodal metastasis. So for at least for staging, para-aortic nodal resection is important. For advanced 3B onwards, as you rightly pointed out, LION trial, where we just need to do debulking. But again, intraoperative
I think
palpation se zyada inspection and seeing them directly.
That point I didn't touch because that is a surgical domain. So that's the reason I didn't touch that point.
Because in LION trial, they had a very good CT scan reporting and all. Many times nodes are missed on CT scan, but when we go in, we definitely see them. So I think watching them, seeing them, and then deciding on debulking, and so that is important. I think you have very completely covered this topic. So I'll hand over to the other chairperson.
Okay. Thank you, Tanushree Jain ma'am. Now I will request Dr. Prachi ma'am to give vote of thanks.
Okay.
Just 1 minute, excuse me. It was a very nice discussion, Dr. Mukesh Bang, Dr. Tanushree Jain, and Dr. Ashish. Thank you very much. And 1 minute, I take this opportunity to invite you all for the Nagpur Hysteroscopy Carnival, which is on 15th, 16th, and 17th December. So it's a very wonderful opportunity to have 4 international faculties and many national faculties. So be there on 15th, 16th, and 17th of December. Thank you very much.
Madam. Definitely will be there. Thank you, madam.
Thank you, madam.
Yeah.
Okay, Prachi, go ahead.
So last and very important note, that is the vote of thanks. Thank you so much, GMC Nagpur, first of all, for coordinating today's thing very well. Vaikar madam, for being there with your students and your staff today. Priyanka was great. Abhijit was very good. And thank you, Dr. Nikita madam, Dr. Niranjan sir, for taking the class so nicely, and this will be preserved in our archives for all the students for always. I have heard Mukesh sir speaking before, and I really wanted it to go to more of students. Like, that was not a recorded session, so now I'm very happy that this will be a recorded session which will be available for all. So thank you, Mukesh sir, and the wonderful discussion Tanushree ma'am and you had. So that added to a lot of the stuff which we again in our archives. So thank you so much, Tanushree ma'am, Ashish sir, for being there for today's talk, and yes, Sushma ma'am and Pragati ma'am always being there for such a close to heart PG education program. Thank you all the audience and Ruchir Corona Remedies for supporting this event, which is going on every fortnightly, and we look forward to many more such sessions. All the students and everyone are invited to please attend us, and keep blessing. Thank you so much.
Especially Dr. Priyanka Shelkar, who was very flawlessly conducted the program, and Dr. Abhijit.
Thank you.
Thank you, Prachi madam. Thank you, Sushma madam.
Thanks a lot.
Thank you, Tanushree. Thank you.
Thank you so much.
Thank you, Priyanka madam.
Thank you, sir.
And congratulations, Abhijit. I gave already
10 out of 10.
Like bevacizumab, but I gave you already 100% point on telling the word bevacizumab.
And I will say that he remembered PARP inhibitors. That was the biggest thing.
That was
I was waiting till
he was slightly scattery on the PARP part, but But I think with
I was
that,
worried he should say at least that much.
Vijit, see, beta, you have been appreciated by all.
Yeah,
Keep it
so
up.
as a
Very
teacher,
nice.
ma'am, I'll just bring him down to floor. So because you have just a long way to go, right? Your JR2 ship is, JR3 ship is just started, right, Abhijit? So yeah, so it's just one case done. Lot of obs and gynac remaining. So keep up the good work that you have done today. Keep up the good work.
thank you, everyone. Thank you.
The best. Yes, I told him. Keep it up.
Thank you, Prachi. Thank you.
Thank you, ma'am.
Okay,
Thank
thank you.
Thank you,
Thank you,
Madam.
Dr. Dhanshi. Thanks all.
Thank you so much.
Thank you.
Bye bye.